Rahim. This is me, Dr. Aman Moeen. Today we will be talking about the Ectopic Pregnancy NICE Guideline. It was first published in 2019 and last updated in August 2023. This is a very important guideline, although it is a very easy guideline, but it will help you to clear your theory exams. The questions coming from early pregnancy module are most likely from the ectopic pregnancy, so you should have a crisp knowledge about the ectopic pregnancy. This topic should be clear to all of you. Okay, this guideline has actually 3 parts. One is about ectopic pregnancy, the other one is about miscarriage, the third part is about pregnancy of unknown location. But today we will be discussing the ectopic pregnancy in detail. Once this concept is clear to all of you, then I will teach you about the miscarriage, how to deal with the miscarriage in the doc station, how to deal with the miscarriage when you get a question in your MRCOG2 exams or you get it in FCPS theory. Okay, so let's start with the presentation. First, you should know about the early pregnancy assessment service. Whenever in some hospitals there is a dedicated early pregnancy assessment service, and this service, it usually is allocated to diagnosis and care of the women who are presenting in the early pregnancy either with pain or bleeding. The service hospital, like the healthcare professional who are here in these dedicated services, they should know how to offer an ultrasound, how to perform it, and then assessment of the beta HCG along with all the signs and symptoms of the patient, and how to come to a conclusion or a diagnosis when they get a patient with early pregnancy, bleeding and pain. Then they can do the ultrasound, they can do the beta HCG and combine all these things together to come to the conclusion of the diagnosis. Okay, and this staff should be trained in sensitive communication and breaking the bad news. So ectopic pregnancy, we already know that it is a pregnancy which is not normal intrauterine pregnancy, but it is located somewhere elsewhere in the body, most likely in the most important part, or the most common is the ampulla of the fallopian tube. Now these are your history questions also, and you can diagnose a patient of the ectopic pregnancy when you get a multiple choice question in your theory exam. So the common symptoms are abdomen or pelvic pain, amenorrhea or misperiod, vaginal bleeding with or without clots. These are the common symptoms, right? A woman would be presenting with abdominal or pelvic pain, amenorrhea or misperiods, vaginal bleeding with or without clots. But you should know about the other reported symptoms as well. These other reported symptoms are the breast tenderness, GI symptoms. She can have diarrhea, dizziness, fainting or syncope, shoulder tip pain, urinary symptoms, passage of the tissue. This is very important. Passage of the tissue is not only the miscarriage, it is also the passage of tissue. Patient can give you a history of ectopic pregnancy as well. Rectal pressure or pain on defecation. Now coming towards, these were all your history points. Okay, now coming towards the signs of the ectopic pregnancy: pelvic tenderness, adnexal tenderness or abdominal tenderness. Whenever the woman is having either of these are the more common signs of ectopic pregnancy. But she can have a cervical motion tenderness, rebound tenderness or peritoneal signs. She can have a pallor, abdominal distension, enlarged uterus, tachycardia of more than 100 beats per minute or hypotension of less than 100/60. Women can present as in a shock or can have a collapse condition. Orthostatic hypotension could be there. This is very important slide for your MRCOG2 candidates, okay? Because they will be asking about these things. These things are given in the guidelines separately, scattered in a scattered form. I put them to the one slide so that you can know about the difference. First of all, I have highlighted which woman you have to directly send to AE, which woman you have to refer immediately to the early pregnancy unit, and which woman you have to just refer to an early pregnancy unit. These are the small and minute points, and these are the EMQs of your MRCOG2. Okay, whenever in a question you get a question like a woman is hemodynamically stable, and you will be getting a tons of the options for that, then you have to select that if the woman is hemodynamically unstable or there is a significant concern about the degree of pain or bleeding, like you are concerned that this pain is severe or the bleeding is heavy, directly refer the patient to A&E. You have to refer immediately to the early pregnancy unit if she is having pain and abdominal tenderness, pelvic tenderness, or cervical motion tenderness. You will routinely refer to an early pregnancy assessment unit if she is having pain, a pregnancy of 6 weeks or more. This is again an important point. Keep this in your mind. Whenever a pregnancy is more than 6 weeks or it is just 6 weeks, then you have to refer the patient to the early assessment unit. Okay, when you are uncertain about the pregnancy gestation, then you should also send the patient to early pregnancy assessment unit. So what is the difference between these three? One is directly referral to the A&E, one is refer immediately, and the other is refer to early. Because in EMQ we have these kinds of options: directly, refer immediately, refer. If a woman is having pain, abdominal tenderness, pelvic tenderness, and cervical motion tenderness, and you just select the option of refer to early pregnancy unit, then your question would be wrong. So this should be very clear to you. The next point I added in this slide just because for the FCPS Part 2 candidates, so that they can utilize it in the counseling. Whenever you should exclude the possibility of the ectopic pregnancy even in the absence of risk factors such as previous ectopic pregnancy. So because what is the reason? Because the third of the women, it means 1/3 means 33% of the women with an ectopic pregnancy will have no known risk factors. Okay, so in this slide the 3 points that I discussed are important. How to do the referrals. The third point is a 6 weeks or more pregnancy, you have to refer to the early pregnancy unit. And if a woman you are suspecting an ectopic pregnancy but she has no risk factor, still you have to think about the ectopic pregnancy because 1/3 of the women have no risk factors, right? Okay, why I was emphasizing on the 6 weeks, because this is the minute details are you will get in your EMQs in MRCOG too. Okay, so if a pregnancy was 6 or more than 6 weeks, you were referring the patient to the early pregnancy unit. But if the woman is having a pregnancy of less than 6 weeks, she is having bleeding, she is coming to GP or coming to A&E or any other doctor, but they will not refer to the early pregnancy assessment unit if her gestation is less than 6 weeks. She is having bleeding, but there is no pain and there are no previous risk factor of ectopic pregnancy. This is an exam question. So how you will explain to this patient? To return if there is bleeding or pain, to repeat the UPT, urine pregnancy test, after 7 to 10 days, and to return if it is positive. A negative test means that the pregnancy has miscarried. Every time if a patient with a positive UPT but her gestational age is less than 6 weeks, there is bleeding but there is no pain and there are no risk factor, you ask this patient to go home and to return if the bleeding continues or the pain develops, and then ask her to do a urine pregnancy test at home in 7 to 10 days and to return if it is positive. Okay, now again the 3 upcoming slides are very important for your theory exam. What are the signs? Also you can utilize it in your clinicals, but for theory, specifically FCPS and MRCOG theory, it is very important. You should be knowing about the signs, those which are indicating the ectopic pregnancy, means tubal ectopic pregnancy, the signs which show high probability of ectopic pregnancy, and a sign just indicating a possible ectopic pregnancy. You should be focusing on these things because you can get these in your exam question. The signs which is indicating that there is an ectopic pregnancy, there is a tubal ectopic pregnancy. It is an adnexal mass moving separate to the ovary. Whenever you see an adnexal mass that is moving separate to ovary, that is the positive sliding sign, and it is comprising a G sac or a yolk sac, right? If this is moving separate to the ovary, comprising a G sac or a yolk sac, it means that it is indicating that there is a tubal ectopic pregnancy, because the gestational sac and yolk sac are the signs of pregnancy. If you cannot see any intrauterine pregnancy and there is an adnexal mass and that is showing a gestational sac or a yolk sac, it means that this is indicating a tubal ectopic pregnancy. The other indication you can get is an adnexal mass moving separate to the ovary, It is also containing a G-sac and a fetal pole, but this fetal pole will be with or without heartbeat. Now, one mass is separate, moving separate to the ovary, but it is containing a gestational sac with a yolk sac. The other one is gestational sac with a fetal pole. So all these things are confirming that this is an ectopic pregnancy. So these signs are indicating that there is a tubal ectopic pregnancy. Now, what are the signs of a high probability of tubal ectopic pregnancy? Now, they will ask you in a question. This is an MRCOG question showing high probability of tubal ectopic. So, whenever they give in a scenario, or they can reverse, they can give the adnexal mass moving separate to the ovary with an empty gestational sac. So, how you will learn about these things? Look, here it's not an empty gestational sac. It is a gestational sac with a yolk sac. So that's why it is indicating that the tubal ectopic is there. But in this scenario, there is a G-sac, but in G-sac there is no yolk sac or no fetal pole. So there is high probability that this gestational sac must be an ectopic one, right? So this is what we call a tubal ring or a Bagel sign, right? Or another possibility, high probability, not possibility, high probability is a complex inhomogeneous mass moving separate to the ovary. This is the most likely scenario you will be getting. Either they will be giving it as a complex inhomogeneous mass, whether it is a high probability of ectopic, possible ectopic, or they can ask which one of the following shows the high probability, possible ectopic, or indicating the ectopic pregnancy. So these should be on your fingertips. Indicating a possible ectopic is, now this is just indicating when there is an empty uterus or a collection of fluid within the uterine cavity, but in adnexa you don't see anything. So this is just indicating a possible ectopic, but no, not a sure shot ectopic or a high probability. Okay, why I added this thing here, that it is very important whenever you are doing ultrasound, whether trans-abdominal or a transvaginal scan in an early pregnancy, you have to check for the moderate amount of the free fluid. 50 to 100 ml of free fluid, or 50 ml more specifically, is insignificant, right? But there is a large when there is a moderate to large amount. So why I have added this point? Because sometimes in the question they give less than 50 ml or 50 ml of free fluid. This 50 ml is insignificant, right? Because it is usually present in the pouch of Douglas. So whenever the fluid is moderate to large in amount, then we can think about the hemoperitoneum. Okay. The other important point, whenever you are doing your FCPS clinical station as well. So if in early pregnancy you have to ask your examiner that I want to do the ultrasound scan, I want to know the thickness, intrauterine, I want to scan for the adnexa to rule out the possibility of heterotrophic pregnancy. That's why I did this point here. Okay. Now coming towards the management of the tubal, we all know that there are three management modalities. One is expectant, one is medical, the other one is surgical. All these are very important for your exam point of view, and also the counseling, right? So expectant management, we have to offer. Now for your MRCOG2 exam, you have to know this thing, that when to offer, when to consider, because this is also important there. Now for FCPS clinical, you can just know about the criteria for offering the expectant management. So the offer expectant management is when all the criteria are present. Okay, there is and in between. Every you see here, there is and. So these all criteria should be fulfilling for a woman to offer the expectant management. The woman should be clinically stable. The woman should have a tubal ectopic pregnancy measuring less than 35 mm, and the serum beta HCG should be of 1000 or less. Okay, and she should be able to return for follow-up. Now the other thing is, when you consider, when all these criteria fulfill, she is stable clinically and the size is less than 35 mm, but the consideration you give to the expectant management is between 1000 to 1500, below 1500, and they are able to return. The only difference between the consider and the offer is the beta HCG level. If the beta HCG is 1000 or less, you can offer the expectant management, but if it is between 1000 and less than 1500, then you can only consider the expectant management. Now once you have put the woman on expectant management, how you will do the follow-up? You will be checking beta HCG level on day 2, 4 and 7 after the original test, and if the level drop by 15% or more from the previous value on day 2, 4 and 7, you have to repeat the test weekly until it is negative or less than 20 international unit. But if the HCG level do not fall by 15% or rise, then you have to seek the senior opinion. Now how you will calculate this 15% rise or drop? The beta HCG value, the highest value you will take minus from the lowest value, divide by the highest value, multiply by the 100. So the highest value would be the first value when you were starting the expectant management and you did beta HCG for the patient. Okay, most likely it would be highest value if the beta HCG is falling, right? So the next value on day 2, it would be less. If it is a failing pregnancy, failing ectopic pregnancy, then the second value would be less. So you minus highest from the lowest, divide by the highest, multiply by 100, and then you get the percentage. And this is important for the counseling of the clinical candidates, that if you offer the expectant management to the woman, and she asks you, what if I just don't take any medicine or methotrexate, or what if I go for the medical management, then you have to explain to them that there is no difference between the rate of ectopic pregnancy ending naturally if we are doing just expectant management or we are giving methotrexate. The risk of tubal rupture with both is the same, and the need for the additional treatment, but that they might need to be admitted urgently if their condition deteriorates, right? Health status, depression and anxiety scores were equal for both of them. Now counseling, now you have to advise that the time taken for the ectopic pregnancy to resolve and future fertility outcome are likely to be the same with either expectant or medical management, and this is an MRCOG exam question. Medical management, the surgical management, whether to give the medical or surgical and how to do the follow-up. So for the medical management, you should know that all the features should be present. The woman should have no significant pain. The size of the ectopic should be less than 35 mm and the beta HCG should be less than 1500, and they should be able to come for the follow-up. When all the features are present, we have to give the medical management. We can offer the methotrexate. So when to offer the surgery as the first line? Previously in the expectant, the all features should be present. The medical, all features should be present. You should know about these minute details also. But for the surgical management, if she is unable to come for follow-up, straightly go ahead with the surgical management. But if she is able to come for the follow-up, but if any of these is present, not all of these, if any of these is present, like if she is having significant pain but the mass is less than 35 mm, still you have to go for surgery. Also select in your exam questions about the surgery. So if an ectopic pregnancy is there with a significant pain, if the mass is more than or equal to 35 mm, the previous two were less than 35 mm. When there is a fetal heartbeat visible, and when there is an ectopic pregnancy with an HCG level of 5000 or more. Okay. Whenever the surgery is indicated, it should be performed laparoscopically whenever possible. So these are the minute points of difference between these. For expectant and for medical, all the criteria should be fulfilled. But for the surgical, if only one criteria is there, you have to go for the surgical management. The other thing is when we can offer the surgery or when we can offer both, like either the surgery or either the methotrexate. So whenever, because at less than 1500 we straight away go for the methotrexate if the criteria fulfills. If it is more than if it is 5000 or more than 5000, then also we go. But if it is less than 5000 or at least 1500, so and all the criteria is present, like no significant pain, no unruptured ectopic, the adrenaxal mass should be less than 35 mm, no visible heartbeat, no intrauterine pregnancy. If all these criteria fulfills, then between 1500 to 5000 we can either offer the methotrexate or the surgical management. The follow-up is for the expectant we do 2, 4 and 7. Here we do 4 and 7 and then weekly serum beta HCG until negative. Now the surgery. Surgery we have two types. Either we go for salpingectomy or we go for salpingotomy. For salpingectomy, we have to offer salpingectomy to a woman when there are no other risk factors for infertility, right? And once the salpingectomy is done, then we do a urine pregnancy test after 3 weeks. Okay, if it is positive, ask her to come back. This 3 weeks test after the salpingectomy is another exam question. For salpingotomy, whenever there are the contralateral tubal damages there, or there are certain risk factors for decreasing the fertility, like previous PID, ectopic, endometriosis, in these women we go for salpingectomy. But we tell them 1 in 5 women, which is equal to 20%, will require further treatment in the form of salpingectomy and methotrexate, and this is another exam question. 1 in 5 mean 20%, and they ask in the exam about 20%. Now salpingotomy, because we have just taken out the ectopic, not the full tube, so we will be doing weekly beta HCG, not the, because for salpingectomy we are doing the urine pregnancy test, but for otomy we are going for the weekly beta HCG. Once the salpingotomy is done, after 7 days of surgery, we take the serum beta HCG and then perform it weekly until it is negative. Okay, I hope this was fruitful for you and you learned something from this presentation. If you like the presentation, please subscribe the channel, like it and share with your colleagues. And if you want any more videos for your gynae and obs, FCPS, clinicals, theory, or you want for MRCOG, to let me know, so I will make more videos for you. Okay, thank you.